Thank you, sir. Good evening, ladies and gentlemen. Well, our patient, a 45-year-old gentleman, diagnosed patient with type 2 diabetes for 4 years and initially with poor glycemic control. 3 months prior to our presentation, he presented with a lateral STEMI, and which he underwent PCI to the LCX. And at that point, it was planned to do a stage PCI to the RCA and LAD. And on examination, his BMI was 28, and the rest of the examination findings were normal. And his basic blood investigations were normal. He had a ejection fraction of more than 60% with no regional wall motion abnormalities. And this was the angiogram. The RCA, you can see there was a proximal tight lesion. The circumflex artery, after the stenting, it was relatively normal. And here you can see the LAD, which there was a tight lesion in the. Yes. You can see the LAD over here. There was a tight lesion here with a acute kind of bend, and there was some calcifications present. And our initial strategy was radial access. First, we thought of doing the LAD lesion, which was more of a complicated lesion, and we thought of using a 6 French XB3 catheter, and of course we anticipated calcium-related complications and challenges, and subsequently we thought of doing the RCA. Of course, our setting was a resource-poor setting, and we did not have IVUS, we did not have rota, and we did not have cutting balloons available. So the lesion was crossed with a Sion blue wire, and we pre-dilated with a 212 a semi-compliant balloon at 14 ATMs. And you can see here, after the initial pre-dilatation, we were not very happy with the initial pre-dilatation. And so subsequently, we pre-dilated again with a 2.5 into 8 NC balloon. And after the initial pre-dilatation, we tried using a stent. We used a 342 stent, and unfortunately the stent, we could not pass the stent through the lesion. So with that, we tried using a guide ciliar catheter extension support due to this heavy calcification. That was our next step. And well, despite using the guide ciliar, still we were not able to pass the stent through that lesion. And well, what happened here was, during passing the guide ciliar, we noticed that the guide ciliar was, we were applying the force, and the guide ciliar was, there was a tendency to bend towards the left main, and it was like bending, giving a force to a ruler from the two sides, sort of, there's a 90-degree pressure going on. And well, suddenly patient, following using the guide extension, patient started complaining of chest pain, and he became hemodynamically unstable. His blood pressure crashed, and we immediately informed the anesthetic team, and with IV fluids and IV inotropes, his blood pressure stabilized. So we did an angiogram after the failed attempt to pass the stent, and this was the angiogram. So it showed a dissection from the left main through the left circumflex artery. So at this point, we somehow secured the circumflex with another Sion blue wire, and left main ostium to circumflex, we stented with a 3.5 into 38 millimeter stent. And then we post-dilated the stent distally with a 3.5 into 12 NC, and proximally with a 4 into 8 NC with a pot. And well, it was a good result. There was a TIMI3 flow. You can see here, TIMI3 flow with the LCX, LAD, and the left main branches. So post-PCI, patient was transferred to the coronary care unit, and aspirin was continued, and we commenced on ticagrelor. He had an uneventful recovery, and we got down the family, and we had a discussion to talk about the next mode of management. So our suggestions were to go ahead with a hybrid strategy with PCI to RCA and do a minimal invasive direct coronary artery bypass to the LAD, or to attempt a PCI at the LAD with full gear, or a CABG. So patient, of course, insisted on going with a CABG in this discussion. So take-home messages here is that risk factors do matter. So we have to acknowledge that certain circumstances like calcified lesions will definitely have an increased iatrogenic left main dissection, and awareness is the key, and vigilance is crucial in a situation like this. And of course, in this case, I know we can argue it that why is it really a guide extension induced dissection? Why it is not a guide catheter induced dissection? Well, of course, what happened was the patient became hemodynamically unstable, and all the blood pressure crashing, the symptoms all occurred after using the guide extension. So especially I want to thank my consultant, especially I want to thank the patient and my supervisor and also my cath lab staff. Thank you.